The levator scapula muscle is one of the most common sites of myofascial pain in the cervical and thoracic region. Understanding its origin, insertion, and unique fiber orientation is critical for any clinician looking to treat upper quarter dysfunction effectively. In this video, we're breaking down the functional anatomy of the levator scapula and demonstrating a precise dry needling technique to help you improve patient outcomes and resolve chronic tension. Disclaimer: educational use only. The content provided in this video is for educational and informational purposes only. It is intended solely for licensed healthcare professionals who have received formal, accredited training in dry needling techniques. Important safety warnings: not for public use. This material does not constitute medical training or certification. It should not be used or attempted by any untrained individual. Do not perform on yourself. Under no circumstances should you attempt to perform dry needling techniques on yourself or others. Attempting these procedures without professional training is extremely dangerous and carries a significant risk of severe injury, including nerve damage, infection, or puncture of vital organs such as lungs. Professional consultation: if you are experiencing pain or dysfunction, please consult with a qualified medical professional or a licensed physical therapist to determine the appropriate treatment plan for your specific condition. By watching this video, you acknowledge that you understand these risks and agree that the creator assumes no liability for any injury, damage, or adverse outcomes resulting from the misuse or attempted replication of the technique shown. So now let's talk over the anatomy of the levator scapula muscles. The levator scapula is a muscle of the posterior thorax, situated at the back and the side of the neck, and it assists with movements of the shoulder girdle. It originates from the transverse processes of vertebrae C1 through C4, and inserts on the superior part of the medial border of the scapula. It's innervated by the dorsal scapular nerve at C5 and has direct branches from nerves C3 and C4. The action of the levator scapula includes elevation and downward rotation of the scapula. We can see in this video here with one of the muscle actions that it allows for this downward elevation that we can see. It also allows for elevation of the scapula as well, which is the act of raising the shoulder towards the ear. The levator scapula also plays a role with shoulder flexion. Agonists or prime movers for levator scapula include the trapezius, the rhomboid major, and rhomboid minor. So now let's take a look at the referral pattern for the levator scapula muscle. Again, here in the diagram, we can see the levator scapula coming off the medial border of the scapula, and its origin points are from C1 to C4. If we look at the referral pattern, we see that most of the medial border of the scapula, as well as the upper portion near where the muscle primarily runs, is the primary sites of pain and discomfort. These symptoms can look like back of the shoulder pain, problems with moving the shoulder and holding the arms up as with folded sheets. Stiff neck is one of the most common presentations, and also upper thoracic pain.
All right, everyone, welcome back to the live demo version of the video. Today we're covering the levator scapula muscle. So this is the muscle that's closest near to the upper trapezius. Again, when we're thinking about doing this muscle, we have to realize that we're in a lung field. So we're going to try to bring the muscle tissue away from the lung field with each part of this. With the levator scapula, I really like to needle it one of two ways. The first way, and my most favorite way, is actually doing it sideline, like we have my patient here right now. I'm mostly just going to use a guide tube to show the fiber orientation, the needle direction that we would needle in. One of my best things and my favorite things to do when needling the levator scapula is, again, we want to make sure that we look at the anatomical landmarks that we're looking at. As we look in the cervical spine, we look for the spinous processes. So again, the first cervical spinous process does not have a major point that we can palpate. But once we roll down on it, I can find the level of C2 here. We're going to walk all the way down to the level of C6, 5, and 6, which is here. And so at the level of C6, this is where I'm going to use as a placeholder for my thumb in this scenario. This is how we can really palpate the levator scapula muscle. Another thing that we want to make sure that we palpate is the superior medial border of the scapula. This allows us to know exactly where the muscle is originating from. So in this case scenario, the way that I like to bias the levator scapula is I will put my thumb right off of the spinous process of C6, and it's almost sitting right over the top of the lamina in this case scenario. What we like to do is bring the scapula into some superior elevation, and then slowly have the patient come down into an inferior depression, and the levator scapula muscle actually falls between my fingers. I can do that same style of pincer palpation, so I'm actually grabbing onto the levator scapula here, and then my needle direction will go straight in here towards my thumb. So I'm needling towards the thumb as a safety or backdrop. Again, kind of peppering through this direction. We can even work up and down different portions of the levator scapula here too, so same rules apply. I can have my patient superiorly elevate and then depress the scapula, and I'm on a different portion of the levator scapula here. This is a really good way to do it from the sideline position. That's actually really safe. If my patient will lie down on their stomach next, I'll show you my other approach that I like to do for the levator scapula. And this next approach utilizes a different position of the shoulder blade entirely, just so that we can bias the more medial superior border of the scapula. What I like to do is actually put the person in what we call a hammerlock position. And this position essentially is taking the shoulder into internal rotation behind the back. By doing that, we're actually allowing for the medial border of the scapula to just be a little bit more biased. Also gets a little bit of the lung field out of the way too. If your patient is hypermobile and they have a little bit more stiffness in their shoulder, you can also utilize a towel to help bolster the shoulder here. But you can also place their hand by their side or their posterior superior to that spine. And this is another way you can kind of bias the levator scapula. But what I'd like to do is stand on the same side of the person. And from here, again, I'm finding that same superior medial border of the scapula. I might even lock them to a little bit more internal rotation. That way that superior medial border will flare a little more. So if you're here for some patients, you can see that the medial border is well exposed and I can really pick up on it. But the levator scapula actually lies on the superior medial border here. I would put like a little towel roll or something underneath the person. In some cases, I can even get creative and just use my knee to help support the patient as well. But from here, I'm gonna find that superior medial border, and we're gonna do another very safe but very shallow technique here. I like to find where the bony border is, and then once I'm here, I insert there, and fiber direction and needle direction is towards the scapula. We're not needling straight down here because again, the lung field is there. We don't want to cause any pneumothorax. But these are the favorite ways that I like to do to needle the levator scapula.
Understanding the intricacies of the levator scapula is a foundational step in treating complex upper quarter dysfunction. Remember, precision and palpation and anatomical knowledge are what distinguish effective dry needling from guesswork. If you're looking to master more techniques like this, check out the links in the description for our full library of clinical masterclasses. Don't forget to subscribe for weekly deep dives into orthopedic assessment and treatment. Stay safe and keep improving your craft.